Thank you for the invitation to do the Lunchtime Seminar. Delighted to be here. With us today is Aine Morrison, the Chief Social Worker with the Department of Health, Office of Social Services, who has commissioned this work, and Emeritus Professor Mary McColgan from Ulster University. On this first slide, you can see the names of researchers that were involved in the project. Some of you would have met them in the process of data collection, doing interviews and focus groups and so forth. And of course, Justin McLaughlin, who's there, who would have done the data analysis across 270 teams regionally from children's and older people services. Alongside this work for safe staffing, there are other arms to the project, which includes mental health, and residential children's teams, and Aine will say a wee bit more about that and about our future plans and ambitions for the wider project and next steps. So I'm going to hand over to Aine to say a few words to set the context for this work. Thank you, Aine.
Thanks very much, Paula, and welcome everyone. I know there's a lot of interest in this subject, so I'm just sort of going to go back a bit and in terms of, well, how did we get to this stage, and how and why did we start the work? And I suppose that the reasons were twofold. I suppose the first was, you know, my awareness of the sort of heavy caseloads that social workers were carrying, and the difficulty that was creating both for services and for individual social workers. I think, if you don't mind, I think maybe somebody has something going on in the background. It'd be helpful if everybody could mute, please.
Yeah.
Okay. Thank you. So yes, so it's about being really conscious of workforce pressures, but not really being able to quantify, you know, what that was or what that meant. So in terms of very much having an awareness that caseloads were too large, but not being able to have a sense of, well, what exactly they should be. And I think, you know, I think we've all grappled with this question for some time. What is a reasonable caseload? What can social workers realistically manage? You know, what level of staffing is needed to provide a good quality service to the people we support? So that was certainly one motivation. And the second motivation was that we were having safe staffing legislation coming in at the department. So some of you will know that the department's commitment to safe staffing arose initially out of a commitment made to nursing during a nursing industrial dispute. And there was an agreement at that point that the department would legislate for safe staffing. At that point, myself and indeed other professions, I suppose, said, well, actually, we think we need this too. So that has been agreed. The legislation, when we eventually get it, will be quite broad. So it isn't going to specify on the face of the bill, you know, what numbers would be, or indeed how we would calculate that. So it will place duties on people to workforce plan, to scope, to have tools, etc. But there will be regulations and guidance sitting underneath that, and that's where we will, I suppose, get into more of the nitty-gritty, and also that it will be tailored to each profession. So social work, I suppose social work is one of the priority groups within that legislation. So at my request, but so I suppose my motivation then was, right, if we're going to have this legislation, it's going to cover social work, we need to be able to quantify what safe staffing is and how we're going to work that out, and how we would implement it. At this stage, the legislation, the sort of broad approach to the legislation is due out for public consultation, I think. Apologies, I should have checked this date before I came on, but I think sometime in July. So would encourage you all to look out for that and respond if you wish. So I suppose I wanted an evidence base for what we were doing. And I wanted to bring as many stakeholders on board as possible. You know, the definitions of safe staffing, calculations of safe staffing are incredibly complex. And I think maybe part of why we haven't done this before is because it is so very complex. So I established groups. I wanted to work with social work academia. And I established groups for each of the programs of care that we were starting with. And that was older people's, children's, mental health, and a specific project on children's homes. To reassure those of you who come from other programs of care, we are not stopping there. There will be, you know, we are planning this year's work to bring in other programs of care as well. There are some, I'll give a few health warnings about this, and if any of you have heard me talk about this before, you'll realize that I give these quite often. So I think we need to understand what safe staffing guidance will be and what it will not be. I've mentioned already the complexity of it, and I suppose within the guidance that we eventually produce, we will be stressing that, you know, staffing needs to be flexible, that it can, you know, that it can never be entirely rigid, that individual caseload management sits with, you know, your senior social worker or your team leader, your line manager, as it has always done. So this is not a tool for managing individual caseloads. What we wanted to do is give broad guidance about the sorts of caseloads that we think are reasonable, and to use that in our planning and in our workforce development and our growing the social work workforce. There will always be the need for emergency responses, for prioritization of work, and we are very committed to a model that is that sort of caseload management is done on the ground in a very collaborative fashion between team staff and the team leader. But Paula will say more. Paula and Mary will say more about that. So I'm going to hand over to Paula and Mary. Where we are at the minute is that we have reports which are, I suppose, providing a baseline and beginning to then tease out the idea of what's a definition of safe staffing, what the principles are, what the key concepts are, and so that will form the basis of the guidance that the department will eventually put out. But I suppose, yeah, so that'll provide the basis. We are going to move on to providing actual numbers, although they'll be expressed in a range rather than a caseload is 25. They would more likely to be a caseload is somewhere between 20 and 25. So at this point, I'll hand over to Paula and Mary, and I'll update on next steps before the end of the webinar.
Thank you very much, Anya. Okay, so just in terms of governance and oversight, Anya has already described the governance and oversight by the Department of Health, and also the steering groups that would have been involved all the way through the project, that would have included representatives from all the trusts, local collaborators that gave us access to data, and linked us in with key people in order to get the data. So we had permissions from the 5 trusts for data collection and honorary contracts and all of that was required to engage in this as a piece of research. We also had permission from the Ulster University for ethics and governance approvals as well. So within the steering groups, there was representatives from not only the trusts, right? There was trade unions, the SPPG from the Department of Health, the British Association of Social Workers, Northern Ireland, and Northern Ireland Social Care Council. So we had a wide range of important perspectives within those steering groups that we met with every month as we not only built the methodology of how to ask the right questions and sense check the data and all of that, but to guide us, you know, and make sure that we were staying on task. So the background Aine has already alluded to in terms of the legislation and policy. And we know that, you know, it'll be within the first couple of years of sitting government. I think that was the planned timeline. I suppose that's hard to kind of actually anticipate exactly, but we know we're on a journey. So the approach that was taken for this piece of work was looking at teams as a unit of analysis in children's and older people services in terms of staffing supply across bandings and service demands. So although this, like our data collection point was February and March 23, and so it's like, you know, you'd be right to say it's a year out of date and, you know, things are maybe different now. It still provides an important snapshot of fairly recent service pressures that gives that overall regional perspective that we didn't previously have. So from it, and not only from collecting the team level data, from all those focus groups and interviews, we were able to build a conceptual framework about what safe staffing needs to be. And that included a definition and 10 principles. So we'll talk a wee bit more about that as we go through the slides. Yeah, so just to reinforce that again, that it was an iterative, consultative research design process with the steering groups and with Aine and the Department of Health colleagues that were all very heavily involved the whole way through as well. So the overall aim, so we get into research speak, we're talking about an evidence-based and empirically rigorous analysis to inform safer staffing levels in social work, including caseload sizes, as Aine said, and a range, and governance and ratio of staffing to service demands. So we were able to take this helicopter view across the region in children's and older people services for the data submitted across the teams. So we'll be able to give you a little bit more about what that actually looks like as the presentation goes on. This image here is at McGee campus at an event at the end of May. Some of you have been present at. Quite an upbeat, although we have a very honest set of presentations. I'm going to let Mary speak a wee bit more to this one. Mary, if you'd like to turn on your mic or off your mic, whatever.
That's grand, Paula. Thank you
right.
very much. And welcome everybody to the webinar today. It's great to see so many people online, and it's an important opportunity for us to feed back the findings which people very kindly engaged with and gave us their time and energy and expertise as collaborators and as members of steering groups. So the objectives of the study were to gather information about the staffing supply of current social work posts in older people services and children's services regionally. We wanted to document the overall average and range of caseload numbers, i.e. the allocated and unallocated cases, including waiting lists at team level, social work activity, vacancies and absences. And with the overall aim of taking a capacity and resource analysis approach to staffing, supply and service demands. And the photograph, as Paula says, is taken on the steps of McGee. It was a conference held in May 23, very well attended. We had international speakers from Finland and from the States talking about their safe staffing legislation, and also representatives from Tusla and from the south of Ireland as well. And I'm sure there's people here on the call who would have participated either in doing presentations in relation to older people or children's services. And as Paula said, it was a very upbeat, very positive opportunity to have a very frank, open and no holds barred discussion about the reality of practice and what was going on and the challenges that were being posed for both managers and social workers alike. Thanks, Paula. In terms of our study methods, we had a team level survey. It was a mixed method study of staffing levels from the 2 dates that information was collected from, either the 28th of February or the 31st of March in each of the trusts, 5 trusts. And we had a total of 249 combining older people's and children's services. So 75 from older people and 174 from children's services. And some teams' data were missing or not reported. We held 10 focus groups with frontline social workers from 5 trusts, 5 for older people and 5 for children's services. And we had 2 focus groups with the steering groups, and as Paul has outlined, who the key stakeholders were in relation to that. And there were 21 individual interviews with social workers across all of the 5 trusts. And we also included a diary activity, which was a week in the life of a social worker in older people services and children's services. The quantitative analysis of the team level survey data involved team type, numbers and level of staff, caseload, allocated, unallocated and waiting lists, and staff ratios to caseload. And we looked at the governance arrangements as well. And Paula will give you more detail in relation to that. The qualitative thematic analysis involved data from interviews and focus groups analysed using a rapid qualitative inquiry approach, where the key challenges were identified with positive and negative examples. And we had cross-cutting emerging themes related to safe staffing and identifying contextual aspects such as travel and risk and the complexity of work which people are now involved in, both in relation to children's services and old people services, and the composite diary analysis of a week in the life of a social worker.
Thank you, Mary. Okay, so this is getting into some of the numbers, right? And each trust were given a unique identifier to, maintain their own confidentiality as a trust. So you can see here in children's services and older people services across all the trusts, the variation in numbers of cases whenever allocated and unallocated cases were added up. So on its own, this doesn't really mean an awful lot, right? But so we're going to just make more sense of that as we move on. Okay, so today we're looking at the numbers in terms of children's services and older people's, right? So some of you on the call will be honing in on what we're saying about children's, and others will be honing in on what we say about older people's. And just to say that the full report is available as well, right? So you can get a wee bit more of the detail. Today, all we're able to do really is give some headlines. So in children's services, you can see Trust A, B, C, D and E, just the number of teams that were analysed. And in older people, similarly, the number of teams that were analysed. And you can see here the valid team numbers versus, the raw data. And that's because not all the teams gave all the full data, so we weren't able to do a full analysis. So the full analysis is for the 174 children's services teams and the 75 older people's. It still gives us really good insights into both service directorates. So just to give you an example, I know this is a very busy looking slide, but I'm hoping that I'll help you to make sense of what it is, right? So I'm going to use family intervention as an example. So we analysed 58 family intervention teams regionally. There was allocated cases, those cases opened to social workers on their workload already. At that time, remember we're talking about February, March 2023, was 4581. Allocated cases were 527. When you add those together, we have 5108. And then we count the number of social workers with caseloads, which was 255.3, which gave us a ratio of social worker to allocated cases 1:18. When we add in those that are on waiting lists, that brings the ratio of social worker to caseload to 1:20. So you can see how that, goes right across all those various team types there. If you can see the gateway as another example, you've got a ratio of open cases 1:13 and 1:23 for those, if you count those that are on waiting lists already. And the reason why we counted the waiting list was because through data collection, teams and individuals were saying that waiting lists come back in often through intake, and so the response then comes back to the team. So being on a waiting list only kind of postpones the pressures the teams were experiencing. So if we look at the rankings then, if we take the caseload sizes and ranks of 0 to 15, 16 to 25, 26 to 35, 36 to 45, or 46 plus, we can see the kind of numbers or percentages of teams regionally that fall within those ranks. Excuse me. So you can see there, you've got 40%, and this is fit again. Just wanted to use like one of the team types. Remember, this is 58 teams. To give you an example, so you know what they look for if you're looking at the main report for your own specific data. So for family intervention, the amount of teams that have 0 to 15 is 40%. 16 to 25 cases is 50%, okay? And then the remaining 10% are from 26 and upwards. And you can see the variation there across the teams, about who has, the higher ends as well. And each of the trusts will know what their identifier is, so as that they can use that information within their own trust to examine it. Now this one, we're given the example on this slide in relation to older people services. And the example I'm going to use here is your community core services. With 56 teams reporting allocated and unallocated cases. And then whenever we look at social workers with caseloads, we're able to see that there's a ratio of 1 to 48 in older people social work. And that's just for allocated cases. When we add in the waiting lists, it becomes 1 to 55. And this is on average. So this is a ratio on average, right? And you can see the other ratios here as well, of the data that was reported. And I suppose what I should be adding when we're looking at all this data is that as far as we possibly could, if something didn't look right, we went back to the trust representatives that gave us the data to sense check it and to make sure that it was accurate. So, we can only analyze what we were given. So if there's accuracy still, because, that these things can happen, we've just analyzed what we were given, basically. Okay, then, and when we look at older people services in the community from a ranking perspective, again, you can see here that you've got your higher weight of 36 to 55 cases at 46% regionally. You can see then 21% are 50, 60, 75, and 13% had 76 and above, up to 95 cases. So, you know, obviously, we're at the higher end when it comes to older people social work caseload sizes. And as part of the work that Aine's describing for next steps, we're going to drill into that a wee bit more, you know, to see why the ratios are so different. So this slide, I have to again, you know, caveat with the health warning that Aine referred to earlier as well. So this is the data that was presented at that time, February to March, talking about the amount of vacancies, and this one is within Children's Services Band 6 vacancies. So reported at that time was 206 vacancies. So that means that of all of those, when people were asked, what are these vacancies? Are they empty posts? Are they maternity leave? Are they sickness? This is the responses that we got. So out of the 206 vacancies at that time, 67% were empty posts. 10% was maternity leave, 16% was sick leave, and 8% related to either other or missing data. So just to give, you know, that broad overview there of the vacancies at that time. And you can see there down the right-hand side of this, that for fit teams, it was 22.4% of their workforce was unfilled at that point. LAC, 22.2%. You can just see the variation there, Gateway 18.7%. So that is the vacancies in children's at that point. Older people services, there was 100.5 posts that were reported as vacant at that time. So between February and March 23. Out of the community, the core older people services, 56 teams, 12.6% had unfilled posts of teams had on mental health. We have only small numbers, so these I would be, you know, exercising some caution with the smaller numbers, you know, but you can see there mental health. It's saying out of 10 teams reported, there was 5 empty posts, 1 maternity leave, 1 sickness, and seven missing data. So, you know, yeah, I think especially with the bigger numbers, whenever we have 56 and 58 teams, you know, the bigger, you know, I think there's more weight and the statistics that we're sharing, and yet I still caveat that with a health warning, you know, that these things can change very quickly, and so it was a snapshot at that time. In terms of assessed year in employment, excuse me, I need water. In terms of assessed year in employment, 22% of family intervention teams, social workers were AYE. 13.5% of the reported staff in Gateway were AYE. 22% of LAC social workers were AYE, and 24% of residential childcare social workers were AYE. Now this is from the reported data, right? So again, all of this needs a health warning, but this was reported to us at this time. Older people community, 11% of community social workers were AYE, and older people mental health, so that was mental health over 65, 5.9% of mental health social workers were AYE. I'm going to hand back to Mary, who's now going to speak a wee bit about our qualitative findings, which again, there's far more depth to in the main baseline analysis report, which is available. Thank you, Mary.
Thanks very much, Paula. These are really the headlines which have emerged from the qualitative analysis of the focus groups and the individual interviews. We were made very clearly aware of team-based approaches to managing caseloads, and there were variations in relation to that, but overall a huge amount of time and commitment to doing that on behalf of both the social workers involved and the team leaders and managers. Staff expressed concerns about burnout and retention in their respective areas, whether that was older people services or children's services. We were struck by the importance of relationships and trust and the role of informal as well as formal supervision. And in terms of the importance of the relationships and trust, we were offered very positive examples of how effectively teams work collaboratively together, supporting one another. And there were team managers who were, Paula used a word earlier on, a helicopter view, who had a helicopter view of the stresses which their colleagues experienced and were working very hard behind the scenes to manage that. And also, in some cases, actually had caseloads themselves. There were positive and negative experiences of caseload weighting models, and to some extent, the jury's out in relation to that, would be our experience at this point in time. For those who have been familiar with the caseload weighting model, they felt it took up a lot of time in supervision, and they didn't have very positive experiences about it. There were some examples where it had worked positively, but that emerged more as a collaborative engagement between members of the team. The Mental Capacity Act was very clearly adding significant pressures to the workforce in relation to older people's services. And some of that is really only beginning to emerge since the instigation of the legislation. There were concerns about office duty, dealing with crisis, and the lack of systematic recording in relation to office duty, particularly in older people's services. But throughout all of this, there was a very strong statement of social work values, both in relation to work with service users and carers and working in communities with children and young people as well, and a strong commitment for social work values in terms of working within teams and in organisations where there was a sense that the corporate risk was being shared, that social workers just at the front line of the workforce weren't actually left to manage that themselves. There was a shared responsibility. Thanks, Paula. We'll move on to the next one. We were very fortunate because in all of the focus groups and in the steering groups, the people who participated did so willingly and with a great deal of commitment. So the definition which you have of defining the safe and effective staffing and social work evolved from both the analysis of the interviews and focus groups. One of our last questions would have been, if we asked you to define safer staffing, what would you say? And so the information has emerged from that. But it is very clearly based on the voice of the workforce and relevant stakeholder perspectives. So safer and effective staffing in social work requires having enough staff with the right knowledge, experience and skills, workload capacity and flexibility to respond to service user needs in an efficient, effective and timely manner. Safer staffing requires regular, supportive, reflective supervision and time to deliver the highest standards of care. This includes having effective and compassionate line management and supportive team with an adequate skill mix and knowledge to support the well-being of team members, in particular early career social workers. Thanks, Paula.
Okay, thank you, Mary. So underpinning that definition, which really has evolved, as Mary has said, it's like a content analysis about what people told us that safe staffing workload should look like. So, so that is the definition, the voice of the workforce, but that is very much underpinned by what evolved to be 10 principles. So this is again, you know, what has emerged from what people told us, right? So the first one is workforce capacity, and that is funding adequate workforce capacity. It's the baseline principle. Second to that is workload within capacity, and that's teams and individual social workers having workload within capacity, ensuring as well that trust, integrity, transparency, fairness, and equity is underpins like workload allocation and the workload that the individuals have. With oversight, as Aine has referred to, that management piece. So I'll come on to that in a later principle. So also related to safe staffing is about a skill mix, knowledge and experience. And that is obviously about, you know, your interdisciplinary supports and assessments and perspectives, but also about your bandings and the support of colleagues that is tailored to specific pieces of work according to their skill base. The fourth is compassionate leadership, and that's about being compassionate and effective in leadership positions. I suppose it's timely with a new leadership framework coming out that very much echoes this same language. Very much related to that is all about well-being. Safe staffing is about workforce well-being and psychological safety. And that is key to retention and supporting staff within the workplace. The next one is camaraderie and support, and they're very much all interlinked. You can just imagine, you know, safe staffing and psychological safety in the context of a secure team that is supportive of each other. So, and related very closely to that, then the seventh principle is about good governance, which includes that feeling of safety in terms of corporate governance and supervision and waiting list management. So it's about that organizational and professional governance, as well as individual team and individual social worker governance. The eighth one is flows on from the rest. I just see this as a really quite sequential. Effective and efficient social work interventions in line with regulatory standards. So that is, if you've all your other ducks lined up, you know, it's going to improve efficient and effective social work interventions for our service users, who are key to all our conversations about safer and effective staffing and social work. The ninth principle is about regular review of workloads during supervision. And the 10th is about closure of cases in a timely manner. And that brings you back to the whole, right round that circle again, about workforce capacity, keeping the amount of work that is there and having to be managed within capacity. And you've got your safer and effective staffing and social work at the centre. So you've your definition, you've got your 10 principles, and now you've got your conceptual framework. And again, this is from the voice of the workforce. So capacity, communication, and connection, 3 C's, quite easy to remember. Because everything that we've talked about, our analysis is really conceptualized within those 3 main concepts. So you've got the underpinning, the 3 C's is the the definitions and the 10 principles. You've got your knowledge and understanding of the systemic and interconnections between these concepts are going to be described now in the next slides. And they are really about what people have told us. So there's a really nice poster if anybody wants it. It in 1A4, or you can print it as whatever size you want. And it brings together the conceptual framework, the definition, and these 10 principles. The first concept is about capacity, and you can see here capacity is underpinned by principles 1, 2, and 3 about workforce capacity and skill mix. about 7, 8, 9 and 10, governance, interventions that are effective, regular review and closure. And really capacity means having enough time to complete all aspects of the job within the parameters of work and time available, and having enough staff to meet the demands of service users' needs in line with regulatory standards as set by the Social Care Council. The second C is communication, and this refers to the open and transparent multi-directional communication between social workers and managers about workload allocations, ensuring the principles of equity, fairness and trust underpin the workplace culture. You know, so really importantly, the voice of social workers were saying that, you know, understanding, you know, maybe the reasons why decisions are made would help people, you know, develop that trust further. So this is underpinned by principles 2, 4 and 5, which is about teams working within capacity, about compassionate leadership, about well-being of social workers, about good governance, about effective interventions and regular review of caseloads. So that, you know, underpinning principles for good communication are set out here. Connection, really critical connection in terms of the need for positive connection through your relationships with individuals and teams, so that workers feel both connected to each other, management and the wider organisation and the social work profession. And it's underpinned by skills mix, principle 3, about compassionate leadership, about well-being, about camaraderie and support, good governance, interventions that are effective, and regular review of cases. And, you know, just one example, and this is on the main report, you know, teams that even with being under pressure, things like daily huddles, you know, we've seen some really nice examples of how teams support each other with difficult work, you know, checking in who's under pressure and acting on that. And so developing the kind of culture that would support camaraderie and well-being. So I'm going to hand back now to Aine, who is going to say a little bit more about where the department is at in terms of next steps. Aine, you okay? You are muted. Sorry, Aine.
Sorry, didn't seem to be switching off for me there. Paula, thanks very much, and thanks to Mary also for taking us through the work that's been done to date. The sort of initial thinking on concepts and definitions and key principles as well. I particularly like the definition and the 3 C's and the 10 principles. You know, to me, they sum up well. I suppose the kind of multifaceted nature of safe staffing. They reflect a little of the complexity as well about ensuring that it happens and that it works. But I think it gives us a very good basis to move forward on. So I suppose what are our next steps? So I am keen to stress that for those of you working in programs of care, which we haven't covered to date, we haven't forgotten about you. So we do feel that the sort of, you know, those sort of basics about definition and principles and core concepts, that they apply across the board. So our intention would be to use that work that is already done. But the programs of care that we want to move into next are learning disability, sensory disability, physical health and disability, and hospital social work. And if I've left anybody out, let me know. Hopefully that covers most people. Oh, sorry, I should have said social work and primary care as well. Now some of those, you know, some of those areas will be closer to the work, say, that's being done already on older people and children's services. Some of them, because of the model of the care they provide, will be quite different. But what we want to do is have a detailed focus look at sort of each area that social workers are working in. Our intention is that we will issue DOH guidance. And at this stage, the timescale is March 2025 for a sort of first iteration of guidance. And that will be the sort of general overall guidance for all social work, and then drilling down into the programs of care that we have started with. I suppose I'm back to the health warnings again, but I suppose just to say, you know, that DOH guidance and eventually legislation, you know, it will not produce either money or social workers. So I see this very much as a sort of a long-term project. And I suppose my approach was to at least start and sort of, you know, get the tools in place, get the guidance in place, and that we will then be able to build up as you know, either our social work numbers increase and finance becomes available as well. I've already said at the beginning, in terms of, you know, I suppose what we envisage the guidance will be, and as I say, it will include the things that Mary and Paula have just talked about, but it will also include, I suppose, recommended ranges for caseloads. But we are very clear, and the guidance will hopefully make this very clear, that we don't see this as something that is hard and fast. What we want it to do is to support people in planning services, to support people to have a sense of, you know, the likely caseloads that somebody will manage. But we are very keen that the application on the ground will always have to, you know, retain that flexibility, and the sort of needs of a service to be responsive on a day-to-day basis as well. So not the easiest balance to strike, and we appreciate that this is very complex. But I do believe we've made a really good start on grasping that nettle of, well, what do we mean when we say safe staffing, and what's a reasonable expectation for a social worker. And those are very important questions that, you know, despite the complexity, I think it's important that we try to answer. I want to thank Mary and Paula, as well as Karen Winter and Gavin Davidson, who are our other academics working on the projects at the minute. Big thank you to my own team, the professional officers in my own team who have been, you know, co-chairs of the steering group, and working very closely with everyone. Huge thank you to all the steering group members, you know, all of those who have contributed data and experiences, and we appreciate just how much of a commitment that is when everybody is so very busy. So we're very, very grateful for that. We will keep you updated, and we will do that in a variety of ways. So we have the Social Work Workforce Implementation Board, and this project sits under that and under that structure. But we will also update through the various fora that the department has as well in relation to social work. So thank you very much. We will keep you posted, and we will, as I say, we will be moving on to other programs of care. So some of you may be getting requests to sort of to join in and support the work that we're doing on this. And you know, we will be issuing guidance. Yeah, March 25. I'll put that out there that's our aim, and at this stage, we are hopeful that we will meet that.
Thank you, Anya. That's great. It's just to add, everybody will be aware of the social work workforce review the Department of Health have completed as well in 22. So the safe staffing sits under recommendation 2B and that as well. Just we've published like a scope and review of safe staffing and workload management and social work, which is international and cross disciplines, because we wanted to look and see what do other disciplines do and what social work doing about this, you know, in other places. So that is an open access, free to download publication. It's on my website. You know, if you go on the Ulster, put in my name, all my publications are sitting there, so you'll be able to access it and download it for free. You'd be able to even Google it and it would come up, I think. So just to say that we've underpinning knowledge from elsewhere as well that's helping and supporting the Department of Health, you know, around their next steps. So that was commissioned by Anya Morrison as well. So thank you to Anya for leading a powerful piece of work. And we've time for questions, if there's any questions. Alison, I'm not sure, I haven't been keeping an eye on the chat.
There's a wee one from Noeline. Noeline,
Okay.
do you want to just read it out or tell Paula what you were asking? Save me reading.
Certainly, Alison, no problem. No, Paula, it was just the point that you made in the report about the review of funded establishment had not taken place for some time. And I suppose just given those comments you've made about demographics, the rise in poverty, cost of living, in addition to those points that have been made, I think, there on the chat box as well, in relation to more specific and specialist roles that social workers are taking on across MCA, adult safeguarding, and in children's as well with PIAs and ABs, etc. Is there a plan to review that as part of looking at the calculation for phase 2?
So Nolene, I think I'll hand you on you for this, because that would be a Department of Health call, you know. Yeah.
Thanks, Paula. You give me the difficult questions.
Sorry, Anya.
I'm just the researcher.
No, Noeline. Yeah, no, look, thanks for the question. I suppose what I would say is, so the social work workforce review, which reported in 2022, you know, it would be part of that sort of review of, well, what social workers do we need and what do we need them doing? And we've certainly very much taken into account new and expanding roles within that. We have used that to make, I suppose, a estimate of the likely growth in the social work workforce that we need, and at this stage we are estimating that we need 60 additional training places for the next 5 years. And some of you, maybe not all of you, may be aware that of the good news that we have 40 additional places this year, not quite 60, but given the financial context, very, very pleased to have those. So I think in some way that's answering part of your question, Nolene, in terms of, well, how many social workers do we need and what do we need them doing? I think there will be the need for ongoing exercises at a more local level as well. The other thing I would say is, you know, there are a number of sort of strategies and ongoing pieces of work. So the mental health strategy is a good example of that, where in terms of, well, what's the model of mental health services we want? That's very much clearly laid out in the mental health strategy. And within that, there's been a multidisciplinary assessment of the type of workforce that we need to deliver on those services. We are also looking, and it sits partly within the safe staffing work, but it also fits with looking at some of our social care workforce as well. So we are looking at skills mix, which again is in part consideration of, well, what do we need, and what do we need them doing? So I think the answer is yes. You know, we are looking at it, but it's happening in a variety of fora, and sort of feeding back into then how we plan services, what sort of model of service do we want, and what, and you know, a very big question about what can we realistically provide and fund as well.
Yeah, no, and that's really helpful. I appreciate there is real validity to this process, and it does need continuous review. That there's no doubt about that. So thanks for that.
Thanks, Nolene. Thanks, Anya. Any other questions?
No other questions, few comments which I'll share with you at the end.
Okay, all right. I suppose just to thank everybody, Anya, thank you, you know, for leading and, you know, developing the structures for the project. I think that's the big strengths, having the steering groups and all the partners from the Department of Health. Thanks to the researchers that did the focus groups and interviews and all the analysis around those as well. But thanks really importantly to those that were interviewed, and to the teams that did focus groups, and to all the people that sat and input the data for team level across all those teams, across the trusts, because without it we wouldn't have been able to produce a report. And report 1 is available for download as well, and the poster. But if anybody is finding any difficulty getting it, if you want to email us, we'll send it to you, okay? And so just this is a, you know, a funding statement, and just that we normally would add the views expressed in the report are the views of the authors and not necessarily those of the funders, in this case the Offices of Social Services. So that's all I think that we have to say. That's my email address if people need it, and that's it. I'm going to stop sharing, I think, now.
Okay. Thank you very much, everyone. Anya, Paula and Mary. It was great to see you again, and thank you very much for taking the time to do the lunchtime seminar today.